Welcome everybody. This is the Point of Care Ultrasound Journal Club for small bowel obstruction. So what we are going to see today, basically the technique to diagnose or to at least see and think about possibility of small bowel disease disorder in adults, plus that could be in kids as well, is the same technique. And then second, we are going to see two studies that has been collected from the ultrasound gel website, which is the website we collect the most news, regarding the ultrasound study currently. Okay, so as I said, this is the reference. So ultrasound gel podcast or ultrasoundgel.com is one of the most important daily for collecting all the last evidence in literature for point of care ultrasound, and is a website divided by subjects. So like gastrointestinal, musculoskeletal, heart ultrasound, lung ultrasound, and so. And there is a lot of podcasts as well that you can listen easily. Every month is updated. So let's talk about GI pathology. So the gastrointestinal pathology with the point of care ultrasound. When we think about what we can see with the point of care ultrasound in our abdomen, despite the EFAS, which is what we know, and then this is the classic knowledge regarding point of care ultrasound in the abdomen and related to trauma, so it's very specific to trauma. So what we can see, is that we can see intussusception, which is regarded to the kids' pathology, so it's mostly in the children. So according to the morbidity and epidemiology is something that you see in the kids, but intussusception can be related to the SBO as well. So you can have an SBO secondary to an intussusception. So diverticulitis as well. This is not the day we are talking on it, but we can see diverticulitis very well. We can see perforation in the diverticulum with the point of care ultrasound because the sick bowel is lying very superficial. Then appendicitis that we all know, and then SBO, small bowel obstruction, perforation as well. In terms of perforation, you cannot rule it out, but you can see air, free air in the abdomen. We will see later on because it's one of the complications of the SBO. Then the gastric content. This is two new articles went up in ultrasound gel podcast regarding the gastric content. There is two new studies. I can even run a point of care ultrasound if in journal club if interested. Incarcerated bowel hernia. This is sometimes related to the small bowel obstruction. Okay, so and colitis. This is more specific for the sonographer more than a point of care ultrasound, but there is some peculiar aspect of the abdomen that you should know regarding colitis, which is something that you can see with the ultrasound very well, especially in Crohn's disease and in ulcerative colitis. Okay, SBO. So before talking about the SBO, we just drop a little bit inside what is the gastrointestinal anatomy. So to understand how the bowel looks like, because this is one of the potential questions every time I receive from fellows. So every time they ask me, yes, but how I distinguish the colon, so how I distinguish the ascending, for example, from the small bowel. So basically the two difference, the big difference in between the big bowel, so we are talking about the colon, and the small bowel is that if I see the intestine, so if I see the colon, is wrong. So what I have to see is just air. What I see is the big enemy of the ultrasound, which is air. When the belly is full of air, this is not something wrong. It's because there is a transit of feces and air in the bowel. So it's absolutely normal. From the esophagus to the rectum, the system of the gastrointestinal layers is multilamellated, so it's like a circumferential multicentric structure. And then we have many layers. The problem is that in the colon, which is our big bowel, we cannot see them. We just see air. So when you see air, it's normal. When you start to see the colon physically, when you see the thickness of the layer, it's pathological, right? This is not the same with the small bowel, because in the small bowel we can see transition of feces, for example. And this is not pathological. That could be absolutely normal. Especially, you will notice this with the kids when come with a very, very tough, hard constipation. You can see a lot of feces, but this is not pathological unless you got a bowel bolus. We will see them after. So disruption of this pattern, which is this pattern, is the diagnosis of the bowel pathology. Either we got a mass and the layers of the mucosa becomes very thick, the wall. Either we got an edema. We were talking before earlier about colitis. So when you see a colon, when the air is substituted by thickness of the wall, this is a colitis. Okay, we are still talking about the colon now. So once again, small bowel, you can see it. Colon, you cannot see it. You just see air. When sometimes you do the fast, and it's very difficult because there is a lot of air. This is a flexor of the colon, the ascending colon. So it's not pathological. It's just what it is because the patient has eaten, for example, 1 hour earlier than the trauma before coming in. So the gas-filled bowel is exactly what I was trying to say. Air-filled bowel limits the ultrasound wave penetration as a hyperechoic stripe, right? And then only anterior bowel is visualized. Yes. So what you see basically is the only anterior part, and it's totally normal. Gut signature, small bowel, 5 alternating bands of high and low echogenicity. So the gut signature is something that belongs just to the small bowel. So this is what you can see. Hey, Mishi, we just started, huh? So, and then if we go ahead, no Doppler sign in the small bowel. If we think about appendicitis, for example, many times I say to the fellow, when you see the appendicitis signs, see also what is basically the Doppler at the appendicitis, because you will see this has described as a ring of fire. So when you got a big inflammation, the amount of vessels and the edema around the walls increase, and then the signal of the Doppler increase as well. So no Doppler signal is a normal bowel. When there is a Doppler, is because a mass is penetrating the walls of the bowel or because there is an inflammation process going on. Again, healthy bowel can be compressed and shift. Every time I say you cannot see the aorta, press a little bit more, move the patient, get back the patient towards the spine, and then probably then you visualize the aorta, because you need to fan around the big enemy, which is the air. And peristalsis is visible in the small bowel, as I said. In the kids that does have a very high level of constipation, you can see a lot of feces moving through the bowel, through the small bowel though. Okay, what is this? This is exactly what we see every time we try to see an aorta and we say there is too much air. This is a normal colon view, and this is basically the visual part of our peritoneum. This is very superficial layer. Is that normal or not? It's normal. This is the view of the colon, so it's absolutely normal. We can be whatever. We can be in the middle. I think we are, because this is the rectum muscle and this is the linea alba. So probably we are in this position, epigastrium level. We can be lateral to the liver, so we will see basically the corner of the liver, and then all air that is masking also sometimes the gallbladder. And if we go ahead here, anatomy again. In the small bowel, I just said, what is air is just colon. In the small bowel, it will be a little bit different. So, because we can actually see the gut signature. So we can see this rounded structure from the outer liner towards the inner side. And this is normal. We will see some image soon. Exactly. This is basically a flat small bowel. When you use your superficial, we will see which kind of technique we need to use to visualize the small bowel. But normally when you use the linear one, the linear probe, and you press a little bit, this is basically the transversal cut of your small bowel, and it's absolutely normal. Something that could be abnormal if we are talking about colon, okay? If the colon is looking like this, either this is a colitis, either there is a mass penetrating the walls of the colon. So is the ranged view. if we are talking about small bowel, this is absolutely normal. So we can visualize from the outer to the inner side until the mucosa, okay? Remember, every time if I'm in the department, I say, what you see close to the liver is the stomach. The stomach is looking like small bowel. It's another structure in your gut that you can visualize. And it's sitting normally very, very high, close to the liver corner and close to the gallbladder, right? And this is the stomach is absolutely normal. And it's looking like the gut signature of the small bowel. Okay, they look close, they look similar, and they are absolutely normal. So again, this is just to remind you the structure of the small bowel that is called gut signature, which is normal. The bright side is the mucosa, and the muscularis is sitting in the outliner and is darker. So, GI and ultrasound, let's talk about the technique very briefly, and then we will talk about SBO. Because this introduction is just to point the fact, again, colon is here, small bowel could be visualized. So if you see the small bowel is not pathological, many times people look at the appendicitis, and because the small bowel is rounded, they confuse appendix with the small bowel. So that's why you need to learn the characteristic, and then it's not pathological. So the techniques first. So there are two techniques. I always say that the best thing to start with is using a convex, basically an ordinary abdominal probe. So the convex, the abdominal one, the big one, that does have the low frequency and more penetration to have just a look all over the abdomen. How do you do it? So many people suggest to look starting from the right iliac fossa and go in this way upside down. So you can see the whole colon. Imagine the colon going like this, right? And then going backwards. And then the small bowel sitting in the epigastrium and middle quadrants, okay? So basically, if you work like this, you will have colon and small bowel. Sometimes the colon is very, very full of feces and air, so you don't see the small bowel. You just see the small bowel maybe lying in the lower quadrants, but this is normal again. Another thing, try to fan the air. So if you apply pressure, you can move the air and then you can reach out the small bowel. Small bowel normally, if there is a lot of air in the colon, is lying superficial, so you can see it. So that is not a problem, but you need to press to get away the air from the colon. And the rest of the abdomen is examined in an individual standardized fashion to ensure complete coverage of the entire GI tract. Again, this is the technique. Just remember the anatomy. And that's why here is the place when the liver sits and there is a lot of air. Here, up here is very easily in the epigastrium. You got still a lot of air because you got the transverse colon. Sometimes it goes a little bit, for example, people that have abdominal colons are very long. It goes a little bit lower as well and mask the small bowel, but this is normal. Graded pressure must be applied to the transducer to get acceptable image. So you can fan away the air. Either sometimes I change the position of the patient. This has happened also when I'm looking at the appendix. Sometimes if it's not so clearly visible, I move the patient toward the left side so I can have the right iliac fossa more visible, okay? But it depends on the technique and how much you're satisfied with your image. So layered normal intestine, again, this is big bowel, so this is colon, easily compressible, normal, no Doppler sign. Intermittent peristalsis, you will see in the small bowel more, or you see a little bit of air moving, but not too much in the colon. It's more in the small bowel. And then the colon does have a thickness of the wall, which is normally less than 4 millimeters. So we don't measure them unless you see a big mass, okay, penetrating the wall. But otherwise, you don't measure them. If you got a colitis, it's very straightforward. You cannot miss it because it gets very thick. The air disappears, and you see the edema of the mucosa. And if you set the Doppler, you see the Doppler pumping out, like coloring the whole image. is very, very clear, very. We call it harmonica sign, but it's very clear. It's thick, the wall, more than 4. Okay, small intestine is thinner than the large intestine, this is for sure. We will see how the SBO looks like. Look at this stuff. So this is vessels, probably iliac vessel. I wonder if this is appendicitis or is just small bowel. So I can't say nothing here, I cannot evaluate this structure. For sure, I tell you, if this structure is sitting here, this is stomach. It's not sitting there because this is vessel, so it looks like iliac vessel. So it looks like an appendix, but I don't know, maybe it's just small bowel. Okay, not pathological finding though. Okay, most bowel pathological finding displays the bowel gas, as I said. So very straightforward to find that target. These findings are replaced by the wall thickness more than 4. Now we got that. So altered blood flow. So normally no Doppler in a normal one. If you see the Doppler, something is going on. In the last 2 patients I have seen last days, so there was a little kid came with the abdominal pain, there was appendicitis. And then was a Rakib patient, he said to me, well, but it's not more than 9 millimeters, the thickness of the appendix, yes, fine, but look at the Doppler. So he had a ring on fire, and then the whole appendix was really catching Doppler. So this is an inflamed status. This is one situation whether the diameter, as by definition, should not be considered pathological. You just say, okay, I've seen the appendix, the tip is not perforated. But that sign of Doppler tells me this is an infection going on, and the patient got a surgery. Leukocyte 20. So, mesenteric lymph node. This is something that you can find with the virosis in the kids. And if you find this in an adult, there could be still a virosis process, but this is pathological. So just mind the gap, something is going on. Unless the patient does have a coli, we don't know. It's very specific. So it's not pathognomonic or nothing, but it's telling you something is wrong or there is an inflammatory answer. Fat stranding around the target area, typical. This is very hyperechoic fat, mesenteric fat that is sitting around the target area. Could be a small bowel, could be a hernia, could be appendicitis, for example. Sometimes, as I said, the appendix is normal, but you can see an abscess and you can see fat stranding. So it's very hyperechoic and it's sitting around the inflamed area. Okay, fat stranding. This is another pathological stuff that will displace the hair again. Free fluid collection, perforated wall, like the diverticulitis, okay? Less compressible or reduced peristalsis. This is another thing. We will see. Right now, we went exactly what we want to talk about today, which is the SBO. So how does it look like with the ultrasound? Now that we got these premises, that's why I want to insist. Thickness of the colon normally is less than 4 millimeters. The colon is not visible unless it's pathological, otherwise it's air. When we are talking about the small bowel, we can see the small bowel. It looks like the stomach, just to simplify the stuff. So you can see the wall, but now, how does it look, the SBO basically? The small bowel, the incidence in, this is an American review of the American literature, they say there is a lot of cases, but the problem is now they're growing because people does have a lot of surgery and because people does have a lot of relapsing small bowel obstruction. This is actually the kind of people, the one that have many episodes. That could be our target in terms of, will I change the plan because I see the small bowel obstruction with the ultrasound? In case of people that have many episodes of small bowel, if you see with the ultrasound, and it happened exactly like 3 weeks to me, that old lady, 85 years old, have like 10 episodes of small bowel, came in, abdominal pain, sudden onset vomiting. There was a clear small bowel. We will see how does it look with the ultrasound. And I put the nasogastrics on, and I called the surgical team, and I asked, sorry, do I really have to do the diety? The surgical team came down and said, well, this is very well known. Probably we do the passage directly, and this is how it went. So the target of the people that we are going to talk today is actually not the one that does have the first event, because the problem of the small bowel, we need to understand what is lying behind it. Whether the ultrasound can show you also the volvulus, the hernia, or the interception. If not, we need to understand whether there is a cancer lying behind. So it's not possible in the reality to just get an ultrasound. What I'm telling you is, by seeing the ultrasound, you know already that the patient doesn't have an appendicitis in this moment, or the patient doesn't have a gallstone, so that is not the priority, okay? Or an ischemia in the bowel, whatever. One diagnosis doesn't rule out the other one, but this helps you a lot thinking about decision making and ongoing plan for the patient, okay? As I always strike with the ultrasound, ultrasound is not the answer for the patient plan, but can help you a lot in the decision making, okay? So a point of care ultrasound can also distinguish, and then they saw this, mechanic and paralytical ileus. Yes, it is, yes, it can, and then this is in the literature. So I put down the through articles, if you're interested, that you can read, because in many cases, point of care ultrasound was able also, as I said, to see the interception, so to understand which was the cause, the primary cause of the small bowel. Okay, so sensibility and sensitivity of the POCUS was in this case, in the literature generally, in the whole, was 92% with a specificity of 96. We will see the two articles that I review for you. This is from Ultrasound Gel podcast and ultrasoundgel.com. So this is the new one. So this is being published in 2018, very, very new. Accuracy of the point of care ultrasound detecting a small bowel obstruction. So this is just a big review. They took the meta-analysis of 4 Cochrane, again, and 3 others, big source of information, PubMed, Medline, Scopus, okay? So basically they saw this and they ran a systematic review because they want to see, you see how long, so almost 30 years collection information. Ultrasound technique, how do I do to get a small bowel ultrasound query or diagnosis? Proficiency of the small bowel ultrasound, so how much time do the fellow need to understand how to see a small bowel obstruction? And the accuracy of the point of care ultrasound is really accurate. What is the sensibility? What is the sensitivity? And in the middle of many points like dilation of the loops or free fluid, what is the most sensitive point? What is the most specific point? And this is what we are going to do. So they say how to, I already told you guys, place the patient supine, okay? Hopefully the patient doesn't have not much air. Start with the low frequency, so deep view, the big one. And then if you want to scan just a small bowel, we will need the high frequency, so what we call the vascular or the linear probe. So, and this is what we need to do. So we scan from the right iliac fossa, and then we go upwards and we continue in this way, okay? And we scan all through the way, the whole wall, abdominal wall. Okay, so this is what we, gentle graded compression, always try to displace, and then this is basically what is suggested. Of course, we will focus in this area more because this is transversal colon, so you cannot see very well. So it lies more in this area. Okay, we can do it together if you got a patient. So, small bowel obstruction, full-filled bowels. Which are the findings that we have if we have a small bowel obstruction? This is basically the most important slide on this presentation, because the fluid-filled bowel loops, so you see the loops like this with this peristalsis. Can you see this almost nothing peristalsis? So we call it to and fro, which means that something is going through, something is coming back. This is calling through and fro peristalsis because it's very, very slow and there is no real peristalsis. Guys, if you have an SBO, you find it straight away. I promise you. Try if you got somebody with the SBO on the DT, and if you didn't do the the CT scan before, try to do it. You know what I mean? Because you will see that. In some places, read the DT if you want to start from there and then, you know, get on, use the vascular probe, get very close to the target area and have a look. You will be surprised how very straightforward it is. And then another thing is the keyboard sign. So the places circularis, so the small bowel is looking like coral inside, okay? Because this is the absorption places circularis. When the small bowel is getting bigger, we will see in the other image, you will see this coral sign inside the lumen, okay? Because it's getting very stretched and is increasing basically the thickness 2.5. So from here to here, it measures more than 2.5 centimeters. This is one of the more specific signs for suggesting small bowel obstruction, plus free fluid in between. Do you remember when we ran the utbildning-vecka for specialists for the ultrasound? Anytime we got a free fluid outside the lumen is pointy. So it's very triangular. We call it tanga sign, that's why. But it's free fluid, okay? The fluid that is contained in the lumen is very circular, right? And is different, whether it's pointing when it's outside. This is free fluid, you got it? This is fluid in the bowel. This is feces and fluid. And of course, the area, they are used opposite. So they're sitting here close to the small bowel target. They are not compressible because you cannot compress it. If you fan around a little bit the air, you come to the target and you will see this area with a very, very lazy peristalsis, okay? Free fluid around the bowel loop seems to be associated to the worst prognosis and surgery. Here we go. What I told you, you will really find it. It's very straightforward because what happened basically, these bowel loops pops on surface. So if you put a vascular, you get it straight away. Again, the distance in between here and here is more than 2.5. There is a little bit of free fluid in between. And this peristalsis, which is again to and fro, very lazy peristalsis, okay? This is a small bowel, this is not normal. Small bowel is completely collapsible, yep.
There it looks super clear.
Yeah.
I'm wondering, why do you not see, why is there no gas? Because if you look at a CT picture, you see these
gas level, right? Because probably, if you moved, you see, here there is a little bit of gas. Yeah. If you moved around, this is just you know, a gift just to make sure that you see that the lumen is more than 2.5, which is one of the most specific. So if you got a lumen more than 2.5, guys, this is an SBO, no matter what. This is an SBO by definition, okay? This is one of the more specific, up to 100% in the last study that I will show you. But this is a good question. It depends on how you cut the loop.
And I think also if you push with the probe, then maybe just push it like just.
Yeah, just fan away the gas. Yeah.
It's just like not just like this.
This is what I was talking to you before. This is another thing very obvious. I will show you my image for my patient. This is the plica circularis. You see, it looks like corals abducting into the lumen. Because it's something that normally, if it's collapsed, you don't see, because it's not collapsed and it's suspending in the fluid. This is basically part of the wall. This is absorption fingertips that you will see that normally you won't see because the lumen is completely collapsed, okay? This is another sign. We call it keyboard sign, okay? But very straightforward, very, I promise you, try to, because it's not the first one that I see. So basically, in this review from 4 different PubMed and other systematic data, so we have that the specificity for dilated loops of the bowel more than 2.5 centimeters does have a specificity which is up to 100%. That's why look for this, whether free fluid is not just specific for an SBO. Free fluid could be due to ascites. Free fluid could be due to just an infection because you got edema around the bowel. So free fluid could be appendicitis because it's perforated or there is an abscess, right? Or whatever, okay? Abnormal peristalsis does have a very high sensitivity, but it's not specific, again, because, for example, if you got a paralytic ileus, which is mechanical, and, a paralytic ileus, which is not mechanical, maybe it's not SBO, but it's due to electrolyte disorder, so it's not specific. Okay, then is the other one, and then we are almost ending the journal club, so if we can go through a question, that will be okay. This is another, still from World Journal of Emergency Medicine this year, accuracy of the abdominal ultrasound for SBO. This is a study in a mono center, so it's a single center study in the tertiary hospital care trauma center. So basically what they did, they say, okay, I teach 3 hours teaching, I teach my fellow EM trainees, US point of care ultrasound fellow and physician, everybody. So how does the point of care ultrasound looks like SBO with the SBO diagnosis? And then they run this for, this is wrong for 1 year, 2015, 2016. Patient enrolled, do the ultrasound and then the CT. By the end of the day, they said, the patient enrolled totally was 64, but in reality 55, just 55 on 64 underwent the CT as a control. The other 8, we will see what they do, okay? What happened is, in this population, they say, okay, how many had the cancer before, which is a high-risk pathology for SBO? How many have the surgery in the abdomen before? And how many had an active malignancy by the time that we saw the patient? So, as you can see, a lot of them had active malignancy, more than 50%, and half of these patients had previously an event which basically put you in a higher risk compared to the normal population, okay? And that's exactly what I like. This is a very important premises. We are talking about patient 50%, so 25, 27 of these patients did have an SBO before, which is very likely that comes again with another event, like the patient that I saw 3 weeks ago. In the totality of the 55, as I said, patient had both CT scan and ultrasound. What happened basically? 8 scans were undetermined. So this is the situation whether it's like a gray area. So the sonographer was unable to say, well, ileus, subileus, I'm not sure. So they say, okay, they take him away, and then we go to the real one, the 47 total, that we did have CT and an ultrasound saying this patient does have a SBO. So what was the sensibility and the specificity? So the sensitivity, was up to 94% of the point of care ultrasound compared to the CT scan. That for me is a very good number. And the specificity was up to 93. Tell me.
Isn't it a bit doubtful to take away those 8 undetermined scans?
I will tell you. Because the problem is, this is the bias that depend on the ultrasound skills and sonographer. They said if we was not sure, because what we are going to see here is, when Serena say this is an SBO, what the CT scan say. That's it. They didn't want grayscale because they want to see exactly the one saying this is a point of care ultrasound SBO diagnosis and what the CT. Otherwise, if you put this one in the gray area, that will screw up your results. In terms of you're not sure if this kind of stuff is going to be really what you want to see, or if this was in a CT scan positive or not. You know what I mean? We don't know if these people did have a CT scan positive or not. And this is one of the limitations of the study as well. Because if that we saw undetermined, that it looks like no SBO, if we put it here and then by the end of the day see the SBO, this drops. Exactly. That's why. Well. And this drops, and then this is they were like me. They don't want to say this. They don't want to see. Probably the sensitivity drops down to 89%. This is a very good point. So for the A patient, the other one. So we were talking about 64. We were talking about 55 that had the CT scan, and in the number of the 55, that 8 dropped down because it was indeterminate. The other 8 that had just, do you remember, from 64 we went down to 55. The 64 minus 55, so the other 8 that did just have the point of care ultrasound but not the CT scan, they said, okay, let's review the diagnosis by the end of the hospital stay, what they say. And basically, again, the number was almost the same. This is wrong, it's not versus. The number was almost the same, so they didn't have the CT scan, but for diagnosis, the sensibility was almost similar, and the specificity was even higher. Did you get it? So the first one, everybody that did point of care ultrasound and CT scan, and the 8 undeterminate. This is the group that didn't get the CT scan from the beginning, but the diagnosis, the final diagnosis, say point of care SBO, and then 94 was the sensitivity, and the specificity was 95. And this, for me, is the most important group because it's telling you these people didn't have the CT, but actually it's quite real. The point of care was quite good in identifying the problem from the beginning. Okay, sorry, this is wrong. Take it away because I copied the other results. This patient didn't have the CT. Limitation, again, the limitation, as you just pointed, is like, okay, that kind of group that was undeterminate, which is a bias for the point of care ultrasound sonographer, by the end of the day, did or didn't have the point of care ultrasound, that's we don't know. Another limitation is a single center study. Another limitation is the capacity of the sonographer. So the big bias, the problem with the point of care ultrasound study is the big bias when we got bias, when we got basically different people from different background doing ultrasound. So you don't know how much is the preparation of sonographer number 1 and how much the skills from sonographer number 2. Because probably in that group of indeterminate, if the sonographer was very skilled, we didn't have 8 indeterminate. It was just no SBO as an answer. And this is a big difference. Because no SBO and CT scan, no SBO, this is part, increase the sensitivity and the specificity, right? Whether indeterminate, we cannot say nothing.
I guess they must have had quite extensive exclusion criteria if they include 55 patients in 1 year, and it's quite a common patient group, so.
I think they got like people from previously abdomen surgical stuff and active malignancy. And then because this kind of people is the most important for us, because the one that present first time with an abdo pain, query SBO, DT by definition, no discussion. You know what I mean? Whether who is coming here, 10 events or DT. The last one 3 weeks ago, you don't want to scan again. You know what I mean? Because it's like you don't want to have a CAT scan because of radiation. So, which is still a good number of population for me. You know what I mean? Plus a little kid with an SBO due to interception. You got the reason why you treat the interception. You don't need to say why the patient does have an SBO if it's very clear in the picture. Again, 50% of these patients, so 32 total on the 64. That we have at a story of active cancer does not represent the general population. Again, exactly. So it looks like it was a little speckle ungulated population in the study. The key points. The patient with the previous SBO, hemodynamically stable, plus point of care ultrasound, which is positive, could be potentially admitted without a CT, and this is the most important stuff. We now know that there are some aspects in the point of care ultrasound SBO diagnosis that we need to know. So the loops of the small bowel, more than 2.5, is very specific. The reduced peristalsis and the free fluid are not so specific sign, especially the free fluid. But the reduced peristalsis does have a high sensitivity though, but it's not specific. So none of them, as you can see, is pathognomonic of point of care ultrasound diagnosis, but they can help you. Altogether, of course, they increase your idea and diagnosis, okay? None of them is pathognomonic. If you got free air in the portal vein, so with the ultrasound, this is a necrotic enterocolitis. This is pathognomonic, right? Here, there is nothing that is pathognomonic, but everything contributes to suggest you to the diagnosis. Plus, this is very specific, okay? So just bear in mind, nothing is saying to you that's for sure, but you, of course, you got a clinical picture plus a couple of elements that are suggestive for. A specific sign such as a free fluid between the bowel and reduced peristalsis, so lazy peristalsis or to and fro sign, helps in the diagnosis, but frequently associated to the other abdominal pathology, right? POCUS and SBO. Last two things, two pearls, complication. I thought about this because I have two patients and I say, well, I should present them. Patient with the hernia can have SBO. And patient with perforation as well because of SBO, because they wait like 48 hours and then they come here because they live in the sheltered home and nobody look at them, okay? They are not passing stools since 2 days and they can have this problem, perforation. How do I see the perforation and how a point of care ultrasound can suggest me? So perforation is a little bit tricky because it's not easy. So the air accumulates in the right upper quadrant, and how do you see the air? Well, in between the liver and the diaphragm, you see like the air that we used to see in the lungs. So you see basically a stripe, like a beeline, a comet tails from the diaphragm, right? And how you can spot it, sometimes you need to move the patient because the air moves accordingly to the position because of the gravity law. That's just to remind you that you can have this problem, okay? Again, the bowel perforation. I always like in my presentation to leave you this kind of information because you can review yourself. So move the patient, which is the position, which kind of probe you should use. Both of them are very good. I normally use, because we are in the abdominal right now, the bowel probe, so the convex, the abdominal, okay? With a low frequency, high penetration, okay? But remember, the gas is very superficial, so you can even get with the vascular one. This is the gas, for example. This is our diaphragm, and this is our liver, and this is basically the artifact of the gas, and this is the reverberation line, typical. You can see this when we are talking about lung ultrasound and air in the lung. Do you remember the A lines, equidistant from the pleura? This is the same presentation, okay? Sometimes you're lucky, you can spot it. Again, this is one single line on top of it. And then another thing is the herniation. So basically, many old people comes with this hernia, and you say, okay, it's an incarcerated hernia, it's just fat in the hernia. What you can do with the ultrasound? Well, the ultrasound is even better than just listening in the hernia if you hear the bowel movements, because you can spot them straight away and you can see whether there is a bowel content in the hernia. And this is for example, two cases then I just throw is my patient, 46 years old, presenting with groin pain, swelling since 2 days, was a lady. So we know that the lady normally are more predisposed to femoral hernia than inguinal hernia. On physical examination, palpable swelling. I was down with the surgical team, I was rounding, and he said, well, but bowel is in or not? Was actually quite popping out, quite big hernia. And I said, okay, we're here, let's do the ultrasound. And this is what the ultrasound showed. This is fat, this is not bowel. There is no bowel. This is free fluid, and there is no bowel in. Because do you remember the bowel does have a wall? The bowel does have eventually that plica circularis. If there is bowel incarcerated, herniated, this is just fat. And how you're sure about it? Well, you put the Doppler as well. You see whether there is some sign. And I cannot spot any, besides the hernia capsula, but I cannot spot any walls here. This is just fat. This is soft tissue inside. Okay?
Would you expect to see gas in there?
Gas, yes. And then also if you hold it still, it's moving. So you see it straight away. I'll show you after. So this is, what is this? I said, look at this. This is probably the door of the hernia, you see? Okay, so no bowel incarceration. In an irreducible hernia, painkillers, discharge home, come back within 2 days. This is very important. This is an important information because the patient will not have any consequence besides just pain. and she can have an elective surgery. So it's a game changer and safe for the patient as well, because yes, you can go and say, well, it doesn't look like, did you pass the stools? Yes. But the fact that the patient does pass the stools is not something that is telling you for sure bowel is not in, because it can create a volvo after 10 hours, for example. Then we go ahead regarding the Mishi answer. You see that? This is another patient presenting with the pain in the groin. It was known for inguinal hernia. And then I said, okay, let's have a look. You see can you see this? This is the plica we were talking about. This is bowel in. This is a bowel in. So you see how much is straightforward? You say, no, oh, wait a minute, this is a bowel. Physical examination, palpable swelling, and then if you see this, it's the same from the other one, so there is no big difference on a clinical examination. And then I couldn't hear nothing, but this is bowel. Okay, yeah?
Oh, that looked like if the bowel is already necrotic in the hernia.
Suggestion? Necrotic Doppler? Put the Doppler on every time, I would suggest. Put the Doppler on, especially in the porta of the hernia, put the Doppler, because it's very suggesting. In this case, I'm moving just to show you the whole stuff. If you stay nice and still, you will at some point see it moving. I'll show you the next one as well. But can you see the big difference, guys? You got it? Yeah.
It's mostly fluid, it's not gas.
Yeah, it's mostly fluid. And then he was incarcerated, so I said, no, we need to act on the patient cannot go home. But it's a very big difference. Here we go, the plica circularis, this is small bowel trapped in. That was you were asking regarding always, this is the hernia neck. If you're here, pop the Doppler just to have a look if it's necrotic or not, okay? Because it could be still alive without any problem, or it could be necrotic that just, help. This is another one. This is another patient mine. So this is a patient coming in with a vomit and constipation, so 3 days, abdo pain. And then I said, in the epigastrium, he did have some sort of mass. And I said, what's going on? Is it cancer or whatever? That was very interesting. Can you see this to and fro sign? Can you see? It's a peristalsis. What is this? Is this bowel or not? Yes, it's bowel. We do have the both, and we do have the plica circularis looking in. Can you see? To and fro. And it was not clear because here I can see an ileus/subileus, but I cannot tell you why. This patient needs a CT for sure, because this is somebody coming in with something weird, but it's very important because I look at I did a fast, there were not free fluid, but I could find this. So I said, there is sign of ileus, and then it confirmed with the CT, came back, there was an ileus because of the cancer lying behind. So in this case, it's not an interception straightforward in the kid who does have a depth of the abdomen, which is like this. So basically, it's very easy to get it, but it's somebody who does have a secondary complication due to something else. With this view, I put the NG tube straight away, yeah. And then I asked for a CT scan. Again, you see, there is a little bit of free fluid in between, and this is still bowel loops. SBO findings, NG tube, fluid, painkillers, CT scan. And CT scan showed me that there was a cancer lying. But what was very nice, that was an ileus, for example, again, okay? So this is how. In this review, you will find how to do it, how does it look like, and a little bit of evidence in the literature. I really like to do it because I think the whole group is not at the point that we are so good in doing ultrasound, so it's very important for me to show you how to do it first and then the evidence, okay? But it's very, believe me, it's very straightforward. Now, when you got an SBO in the CT scan, try to have a look at it. Find a little bit the air and try to see the peristalsis, especially is unexplained bowel pain or unexplained abdo pain in a patient that can have a risk factor like adherences, endometriosis before, or previous surgery, okay?
80% of obstruction, bowel obstruction.
A lot.
Surgery. But 20% is others, like spontan adhesions.
Happy? Okay.